This is lecture 8 in this course on antibiotics. The topic is important side effects and toxicities. The learning objectives are first to know the common side effects and toxicities of antibiotics, including allergic reactions, diarrhea, C. diff colitis, QT prolongation, and interactions with warfarin. And second, to be able to adjust dosing of vancomycin and the aminoglycosides in response to serum drug levels. There are many drug side effects, and a single lecture could never possibly be comprehensive enough to cover them all. This will just highlight a few of the most commonly discussed concerns on the wards. This lecture should not be used as a substitute for researching the toxicities of specific medications prior to their administration in actual patients. I'll start with a discussion of allergic reactions. Unless you are a pediatrician, the reason to understand allergies when prescribing antibiotics is not as much because your patients are likely to suffer an allergic reaction afterwards, as it is because your patients will commonly report allergies to antibiotics they've received in the past before you prescribe them something, particularly penicillin and to a lesser extent trimethoprim sulfamethoxazole or quinolone. To understand how to approach a patient with a reported antibiotic allergy, one first must know something about the types of allergic reactions. Most clinicians still use the Gell and Coombs classification system when talking about allergies. This system subdivides immunologic reactions into 4 types. Type 1, which is mediated by IgE, is responsible for anaphylaxis, angioedema, bronchospasm, and urticaria, otherwise known as hives. Type 2 reactions, which are described as antibody-dependent cytotoxicity, results in hemolytic anemia and thrombocytopenia. Type 3 is immune complex mediated and results in a relatively obscure entity called serum sickness. And finally, type 4, also known as cell-mediated or delayed hypersensitivity, is responsible for maculopapular drug reactions, as well as the severe dermatologic disorders Stevens-Johnson syndrome and toxic epidermal necrolysis. In general, it is the type 1 reactions, as well as the severe dermatologic conditions, that are of concern when someone reports a history of drug allergy. A history of an uncomplicated maculopapular drug rash, for example, presents little to no increased risk of a life-threatening reaction if the patient is exposed to the same or similar drugs again. Here are some important points about patient reporting of a prior drug allergy. First, reporting of an antibiotic allergy is not reliable. For many patients, the supposed reactions occurred in childhood, and they no longer even recall the actual reaction themselves. In fact, multiple studies consistently have found that only 10 to 15% of patients who self-report a history of penicillin allergy are actually shown to be allergic after undergoing skin testing. One reason for this is that patients may incorrectly report adverse reactions such as nausea, diarrhea, and headache as allergies. And some patients eventually lose their anti-medication IgE after enough time has elapsed since their last systemic reaction, which may require 10 years or more. Patients with specific reaction histories are much more likely to be truly allergic than those with vague histories. For example, if a patient were to tell me that she can't take penicillin because she had, quote, anaphylaxis, requiring a week-long hospitalization after a dose of amoxicillin, I would believe that much more so than if a patient reported that she can't take penicillin because her parents always told her something bad had happened after she was given it as a baby. If the question of a true allergy is in doubt, which it commonly is, referral to an allergist for skin testing is appropriate for patients who report an allergy to more than one class of antibiotics, as they will necessarily have much fewer options to use when they get sick. Although clinicians frequently write off patients who report allergies to multiple different drug classes as overreporting of common side effects, there is an entity known as multiple drug allergy syndrome. I personally can recall one woman I cared for who had well-documented anaphylaxis to penicillins, sulfa, and quinolones, none of which are structurally similar to one another, the combination of which would be expected to have an incidence on the order of 1 in a trillion if some factors such as genetics weren't playing a role in a dysfunctionally hypervigilant immune system. Skin testing is also appropriate for patients who report an allergy to a major antibiotic class, and to require frequent courses of antibiotics, such as a patient with cystic fibrosis, frequent COPD exacerbations, or a diabetic with recurrent foot infections. I'll next talk for a few minutes about penicillin and cephalosporin cross-reactivity, as this issue comes up all the time both on the wards and in clinic. One common scenario is a patient who is admitted with community-acquired pneumonia and reports a history of a penicillin allergy, leading the treating team and/or pharmacist to be apprehensive about giving ceftriaxone. There is a widely cited fact that 10% of patients with an allergic reaction to penicillin will have a cross-reaction to a cephalosporin. This is completely false. This dramatic overestimate is based on studies from the 1960s and 70s, which had significant methodological flaws, among which were an inappropriately loose definition of allergy. These studies were done during a time when drug manufacturing techniques led to greater risk than today of contamination of one drug with another. Also, they failed to account for the observation that patients with significant allergies to penicillins actually have an increased risk of allergy to any medication, irrespective of structural similarities. In reality, the risk of cross-reaction between penicillins and cephalosporins has been reported to be as low as 0.5 to 2.5% for first-generation cephalosporins, and near zero for most second, third, and fourth-generation cephalosporins. The likely reason for this difference between generations is that first-generation cephalosporins generally have side chains which are structurally more similar to penicillins than do the other generations. Let's look at those side chains in more detail. Here are the general structures of the penicillins and cephalosporins. We can see that 4-member beta-lactam ring in the middle of both. In addition, penicillins have one variable side chain, denoted here by the letter R, and cephalosporins have 2. It is these side chains which are responsible for the differences in activity and effect between members within the same class. Although there is some debate about this, the beta-lactam ring itself is thought to be generally an uncommon trigger for an immunogenic response, and true allergies are usually triggered by an R side chain. To understand what this means, let's compare the penicillin amoxicillin and the first-generation cephalosporin cephalexin. Notice how similar these two side chains are. While not quite identical, the degree of similarity suggests the possibility of a cross-reaction between these two drugs. In contrast, here is the structure of the third-generation cephalosporin ceftazidime. That side chain is dramatically different, leading to a near-zero risk of cross-reaction. In summary, patients who report a penicillin allergy can be safely given a cephalosporin if all of the following are met. The allergy history is not suggestive of a type 1 or IgE-mediated reaction. The reaction occurred more than 10 years ago. And the cephalosporin has a dissimilar side chain from the penicillin. Otherwise, the clinician must weigh risks and benefits of administration of a cephalosporin. One more thing before moving on, one should always consider medical legal liability based on your medical community's common practice and standards of care prior to prescribing cephalosporins in patients with a reported history of penicillin allergy. The aforementioned 10% cross-reactivity rate is still widely cited and believed, even if it's not true. When it comes to being sued or reprimanded by your institution, common perception usually carries greater weight than scientific truth. The next side effect I will discuss is antibiotic-associated diarrhea. This is actually much more common than allergic reactions and refers to any otherwise unexplained diarrhea occurring during or immediately following antibiotic administration. It may be caused by multiple mechanisms. Alterations in bowel flora, for example C. diff colitis. The metabolic consequences of an overall reduction in bowel flora, for example decreased metabolism of carbohydrates may lead to an osmotic diarrhea. Or finally, the direct effects of antibiotics on intestinal mucosa. For example, erythromycin acts as a motilin receptor agonist. Of these mechanisms, C. diff colitis is the most severe and the only one that usually requires direct treatment aside from cessation of the causative antibiotic. Clostridium difficile, as it's more formally known, causes colitis through release of a toxin. It is responsible for 10 to 20% of antibiotic-associated diarrhea. Over recent years, C. diff infections have become more prevalent, more severe, more refractory to standard therapy, and more likely to relapse. There are many risk factors for the development of C. diff colitis. Its primary risk factor, as its inclusion in this lecture would suggest, is recent antibiotic use. The highest risk antibiotics are clindamycin, broad-spectrum beta-lactams such as piperacillin and tazobactam, and the quinolones. Moderate risk antibiotics are other beta-lactams, macrolides, and trimethoprim sulfamethoxazole. The lowest risk antibiotics are the aminoglycosides and metronidazole. Other risk factors include hospitalization, advanced age, therapy with a proton pump inhibitor, enteral feeding, and being status post-abdominal surgery. As discussed in Lecture 6, the only two commonly used antibiotics that are active against C. diff are metronidazole and oral vancomycin. Another concerning antibiotic toxicity is prolongation of the QT interval on EKG, leading to a potentially fatal heart rhythm called torsade. For example, here is a normal heart rhythm with a corrected QT interval of 450 milliseconds. And here is what happened immediately after administration of 500 milligrams of IV azithromycin. The time duration between the onset of the QRS complex and the end of the T wave has dramatically lengthened. The most common drugs to cause this include macrolides, such as erythromycin and azithromycin, and quinolones. In addition to the choice of antibiotic, there are other specific risk factors for developing drug-induced torsade as a consequence of a prolonged QT interval. Modifiable risk factors include a high dose of the antibiotic, rapid infusion, concurrent use of other QT prolonging drugs, and electrolyte abnormalities, particularly hypokalemia and hypomagnesemia. Non-modifiable risk factors include advanced age, baseline QT prolongation, and bradycardia. Yet another common toxicity involves interactions between antibiotics and warfarin, also known as Coumadin. Warfarin is a common oral anticoagulant used in the treatment of patients with venous thromboembolism, atrial fibrillation, and mechanical heart valves. It has a narrow therapeutic range and requires frequent monitoring of the INR to prevent excessive risk of bleeding. Concurrent use of antibiotics is associated with an increased risk of over-anticoagulation. The major mechanism for this is via a disruption of normal intestinal flora that synthesize vitamin K, which is a cofactor for the body's endogenous clotting factors, and thus it antagonizes the actions of warfarin. As with C. diff colitis and QT prolongation, the risk of a clinically significant interaction with warfarin is not the same for all antibiotics. Here are the results of a case control study of 39,000 patients aged 65 and over on warfarin, and the odds ratio for needing hospitalization due to excessive bleeding, broken down by class of antibiotic administered. For those of you not familiar with odds ratios, an odds ratio of 1 means there is no increased risk. Odds ratio greater than 1 means there is an increased risk. And so all antibiotics here were actually associated with increased risk, and all of these were statistically significant. The fact that the greatest effect was seen with the azole antifungals and trimethoprim sulfamethoxazole is due to their inhibition of CYP2C9, one of the main enzymes responsible for metabolizing warfarin. The consequence of the findings of this study is that a patient's INR, which is a surrogate for the anticoagulation effect of warfarin, should be monitored at least weekly for patients on concurrent antibiotics, and probably more frequently for patients with additional risk factors for bleeding. Occasionally, for patients on warfarin for atrial fibrillation or other low-risk indications, the warfarin dose may even be proactively lowered when antibiotics are started. There are many other important antibiotic toxicities, many of which are specific to individual drugs or drug classes, and many of which are idiosyncratic in nature. I'm going to quickly run through a list of ones which the average internist should know. Some of these will hopefully sound familiar from prior lectures. Ceftriaxone can lead to something called biliary sludge, which occurs when solutes in bile precipitate in the gallbladder. Although it's not a solid gallstone in the traditional sense, it predisposes the patient to all of the same complications as gallstones, including biliary colic, acute cholecystitis, and pancreatitis. Vancomycin causes a self-limited cutaneous flushing of the neck and upper torso, known as red man syndrome or occasionally as red neck syndrome. It also causes ototoxicity and, although not listed, on rare occasions, nephrotoxicity. Daptomycin can cause a myopathy, requiring weekly checks of creatine kinase. It has also been very rarely associated with an eosinophilic pneumonia. Tigecycline can lead to transaminitis and photosensitivity. Linezolid, which most people love as it is the only oral medication that very reliably covers hospital-acquired MRSA, unfortunately has many side effects. They include reversible myeloid suppression, lactic acidosis, peripheral neuropathy, optic neuritis, and serotonin syndrome when combined with other serotonergic drugs. Aside from serotonin syndrome, the other toxicities of linezolid generally occur only after 2 weeks of treatment, which is why some clinicians limit linezolid courses to that duration. Quinupristin dalfopristin, commonly known as Sinercid, leads to myalgias and arthralgias in nearly half of patients. Like linezolid, the quinolones have a number of seemingly random toxicities. In addition to QT prolongation, they can cause either hypo or hyperglycemia, tendinopathy, and a false positive urine tox screen for opiates. They can also exacerbate myasthenia gravis and are considered contraindicated in patients with that condition. Trimethoprim sulfamethoxazole can lead to hyperkalemia, which I've found to be a relatively common side effect. Nitrofurantoin has a rare idiosyncratic toxicity of pulmonary fibrosis, which can be fatal, along with hepatitis. Colistin has significant rates of nephrotoxicity and neurotoxicity. Carbapenems may lower seizure threshold. Metronidazole has a disulfiram effect in which the drug interferes with the metabolism of ethanol, leading to a buildup of intermediate metabolites that can make people feel awful after consuming alcohol. Doxycycline leads to erosive esophagitis, necessitating its administration with plenty of fluid and not at bedtime. It can also cause photosensitivity. Finally, the aminoglycosides, in addition to substantial nephrotoxicity, can also exacerbate myasthenia gravis and, like the quinolones, are contraindicated in those patients. I'm going to conclude this lecture by discussing the antibiotics whose serum concentrations are frequently monitored. They are vancomycin and the aminoglycosides. Monitoring serum drug concentration is to both prevent toxicity from excessive levels, as well as prevent the development of resistance from inadequate levels. There is no one succinct reason why clinicians and pharmacists usually only monitored vancomycin and the aminoglycosides, but it partially is a consequence of difficult to predict distribution and elimination, readily available and reliable drug assays, and a relatively narrow therapeutic window, particularly for the aminoglycosides. Initial dosing of vancomycin is based on actual weight, renal function, and target concentration. There exist tables and numerous sources on the internet of appropriate starting dose depending upon these parameters. The prior practice of starting with 1 gram Q12 hours in all patients is outdated and frequently underdoses. The antimicrobial activity of vancomycin is related to the time the serum drug concentration exceeds the minimum inhibitory concentration, or MIC, of the target organism, which will be discussed more in Lecture 9. Thus, unlike the aminoglycosides, only the vancomycin trough level is of concern, and not the peak level. The target trough level depends upon the indication. It's 15 to 20 micrograms per milliliter for bacteremia, healthcare-associated or nosocomial pneumonia, endocarditis, osteomyelitis, prosthetic joint infections, and meningitis. It's 10 to 15 for everyone else. A vancomycin trough level should be checked 30 minutes before the 4th or 5th dose. Adjustments in dose without altering dosing frequency will result in proportional changes in trough concentration. For example, imagine a patient on 1,000 milligrams Q12 who has a target trough of 15 to 20, but whose measured trough level is only 10. To achieve a target of at least 15, one would need to increase the dose to 1500 mg Q12. Once the target concentration is achieved, the trough level should still be monitored weekly for patients with any of the following: a target trough of 15 to 20, unstable renal function, hemodynamics, morbid obesity or those on dialysis, or concurrent use of other nephrotoxic agents, particularly the aminoglycosides. For all of these patients, the renal function should be monitored at least as frequently as the drug level. When it comes to the aminoglycosides, serum drug concentrations should be routinely monitored in all patients. Unlike vancomycin, whose antimicrobial activity is time-dependent, the aminoglycosides activity is concentration-dependent, which means that it is dependent upon how much higher the concentration gets above the minimum inhibitory concentration. Also, the risk of nephrotoxicity and permanent ototoxicity are directly related to both the peak and the trough levels. In other words, the aminoglycosides have a narrow therapeutic index. Therefore, both the peak and trough level should be monitored, with the trough level within 30 minutes prior to the next expected dose, and the peak level within 30 to 60 minutes after the end of the previous dose. As with vancomycin, target levels depend upon indication. Regarding the target trough level for gentamicin and tobramycin, it is 1 to 2 micrograms per deciliter for life-threatening gram-negative infections, and less than 1 for all other infections. For target peak level, it is 3 to 4 when gentamicin is being used for synergy in gram-positive infections, 8 to 10 for gram-negative pneumonia or in life-threatening gram-negative infections, and 6 to 8 for everything else. Redosing of aminoglycosides follows the same general principles as vancomycin, but given the narrow therapeutic index and the added complexity of worrying about both peak and trough levels, it is best done in close consultation with a pharmacist. That concludes this lecture on important side effects and toxicities of antibiotics. The next lecture will discuss antibiotic resistance.